I was just thinking back in the day, the number one thing when I started 30 years ago with prolotherapy, it was low back pain. And Dr. Hackett, who coined the term prolotherapy, many of his papers were on low back pain. And he had, when it was all tabulated, he had treated, this is published back in the 1950s, he had treated 1,800
Wow.
people with prolotherapy, and the cure rate he had was 82% of chronic low back pain.
I believe it.
And then I'm reminded also, I was at one of the main stem cell conferences, this is probably like 10 years ago, and there was an orthopedic surgeon on the panel, and they were just asking a bunch of questions, and he made this statement, it was one sentence, and I'm sure many of the people would have overlooked this statement, but he said, yes, it's all micro instability. Like he was saying, like, it's all micro instability. So Danielle, how would you define lumbar instability, and how does that cause low back pain or chronic low back pain?
We call a lot of it micro instability too. In my mind, like I would define a macro instability, like something that's huge, like maybe from a fracture or something much more severe. But micro instability meaning more from whether it's subtle or from a trauma, ligament laxity. So we know that ligaments are the main stabilizers of our spine, really our whole skeleton. And so if you stretch them out, whether it's again like with a big trauma or just slowly over time, you're going to develop little instabilities, usually at multiple levels.
Yeah, that's exactly right. One of the ways, that we test for instability is with dynamic motion scanning or digital motion x-ray. So this was actually one of the patients. So you could see where the patient with fluoroscopy, they were actually, bending down and then they were extending, and you could see where here it's George's line, or the line at the end of the vertebrae are all together, where here it's like walking down steps. So we would call this instability.
A lot of patients in my practice have low back pain and have low back instability. And majority of the time, if you think about people that throw their back out, so to speak, usually people throw their back out when they're bending forward. A lot of times, honestly, people are like brushing their teeth and they go to spit and they throw their back out, or they maybe go to lift something that was heavier than they thought. It's, in my practice, much more common to see instability in this way when you're leaning forward versus extending back.
A lot of times we don't talk about it that much, and we probably should do it more, is that there's many similarities between the neck and the lower back. So, the lumbar spine's supposed to be lordotic.
Yeah.
And then it's interesting to me that the same process that screws up the neck, forward head, face down lifestyle, right? Well, technically when we sit, right, we're supposed to be like this, when you're at the computer, but let's be honest, usually we're like this. So the same forward head, face down lifestyle with sitting, which stretches out the cervical ligaments, also flexes the lumbar spine and then stretches out the posterior ligament complex. So if you said to me, what is the number one cause of chronic low back pain, in a weird sort of way, I'd say it's slouching.
Yeah.
It's improper mechanics when you're sitting, whether you're watching a football game, right? It's football season.
Or like a lot of people are working from home. So if you're on the computer a lot, maybe you're even in your recliner using your computer, or you're like laying in your bed in a weird position using your laptop. We've all done it, but you do that for a long period of time. It could, really those small forces can end up being over time the same force as if you were in a car accident.
In medicine, we call that creep. So creep is a slow stretching of ligaments. The easiest way to keep your lumbar spine in extension is just to have your computer up, and then have your chest up. So whenever we don't feel our lower back muscles contracted, we're going to put them in the flex position, and then that you're basically going to get injury of the ligaments, and then you're going to see, this is called anterolisthesis, and that's often what we see, and the treatment of choice for that is prolotherapy. And then sometimes even on just regular x-ray, you can see spondylolisthesis or anterolisthesis, where you could see the L4 is in front of the L5.
So sometimes like you said, like this is a what we call like a plain x-ray. So this patient isn't even bending forward or leaning back. Sometimes you'll see like things might look quote unquote normal until you actually make them move. So like you said, sometimes you'll see it on a plain x-ray, but sometimes you actually do need a motion scan to see it.
Do you order a lot of flexion extension MRIs? You know, if so, why or why not?
I don't order a lot of flexion extension MRIs. Sometimes, yeah, more so like a flexion extension x-ray to look for instability. Okay. I would more do an MRI in my practice if someone had maybe more like complex neurologic symptoms. Like I just had a patient recently who whenever she could stand up from a sitting position, and she could stand for a second, but then she had to immediately hunch over, and that was the only way she could walk because of severe pain.
What I like about flexion extension x-rays is that, you know, and what I tell people is try to go to the x-ray place, relax, like maybe even take a muscle relaxer or something, and then do some flexion extension before they take the x-ray, because you're trying to relax the muscle.
Yeah.
So then when you hold it, it's going to show the instability. Because, you know, if your muscles are all tight, when you do a flexion extension MRI or x-ray, it's not going to show the instability. So we would just call that a false negative. You have instability, but it's not showing it.
Your muscles are doing a good job guarding it for you. So someone that might have like a pinched nerve feeling, but they don't have it all the time, they only have it with certain positions, you would see, if you can see here too, like the space here for the nerve is bigger than it is down here at L5S1. And then with flexion, it gets even bigger except for that L5S1. And then with extension, it's completely closed off. So we would expect that person to probably have some significant pain if they ever were in a position leaning back. They might be a sloucher because it feels better. They don't have any pain.
Yeah, I guess you're actually right, because they're flexed. Yeah, that's a good point. Because, you know, we'll hear people say, well, my MRI was negative.
Yeah.
You know, so you could still have a pinched nerve even though the MRI is negative, because the MRI is done in the laying down position where the flexion extension MRI is upright, and then of course these are upright. Because most people have symptoms, like this person we would suspect would have symptoms when they're walking or something, because they're in this position when they're walking. Now this person still has the lordotic curve. So, you know, we see a lot of people where it's straight. So straight means you've lost your lordotic curve. When you lose your lordotic curve, you can't bear weight as good. So that puts more strain on the ligaments. You're actually making yourself more prone to getting ligament injury in your lower back, and thus chronic low back pain. Here's the ligaments. Now, normally in prolotherapy, right, we're treating the posterior ligament complex, which is all these ligaments, and you wrote a whole paper on the capsular ligaments. So what are the capsular ligaments?
So the capsular ligaments, a lot of people are familiar with facet joints, or that term. So capsular ligaments enclose that facet joint. So if you look here, this vertebrae and this piece that comes out, and then this vertebrae and this piece that comes out, this capsular ligament encloses the facet joint that connects those vertebrae together. So it's a very important stabilizer of that posterior part of your spinal column.
And if we think about it, where the joining vertebral bones meet, it's actually at the facet joint. So the motion that we're going to have, most of the motion is going to occur at the facet joint. So it makes sense that the most important ligaments as it relates to stabilizing the spine is going to be the capsular ligaments.
And you have, like, this is just showing one side. You have one on each, like left and right. You have one on each side, anchoring those vertebrae together.
If somebody's, like, what's the difference between, say, somebody getting a facet joint injection with steroid versus prolotherapy? So why should somebody get prolotherapy instead of, like, even a medial branch nerve block? You hear that a lot. So the doctors block the nerve to the capsular ligaments. So the choice is somebody could get as a steroid shot into the facet joint, blocking of the nerve that goes to the facet joint, or prolotherapy. Why would you say prolotherapy is a better option?
So in comparison between prolotherapy and steroid shots, although there really is no comparison, steroid shots honestly might help your pain temporarily, but it comes at a cost. So anytime you put a steroid into a joint, or even like into or around soft tissue, it actually increases and accelerates the degeneration going on. So someone might feel better from a steroid shot into their facet joint for some time, whether that's a month, 3 months, we don't know. But during that time, two things are happening. One, the steroid is actively degenerating at a faster rate. And two, the patient doesn't feel the pain, so they might be doing activities that they shouldn't be doing because they're missing that signal of their body saying, hey, don't do this, you're causing damage. So the two together are not good over time. A medial branch block, the medial branch nerve, I mean, that's what innervates the facet joint. So if you block that nerve, it might help your pain because you've, disrupted that nerve signal of pain, but you haven't done anything to heal the joint. Maybe you've confirmed that that joint is what's causing the pain, which is not a bad thing, but nothing is actually healing the joint. So once that nerve block wears off, you're going to be right back where you started, if not worse.
Yeah, and then why would you get prolotherapy, instead of those other options?
So prolotherapy in its nature is actually going to work to heal those ligaments. It's actually going to work to strengthen that joint as a whole. So if you're someone, that has chronic pain or a history of, pain on and off throughout the years, you can't get a hold of it, you've changed your lifestyle because you can no longer do the things that you want to do for back pain, things like steroid shots and medial branch blocks are not going to help you. If we can actually restore the joint, restore the function of the joint in a natural way, which is what prolotherapy does, you're going to be much better off long term.
Even in some patients where they've had positive effects, like let's just say somebody said those things do help, the steroid shot or the branch block helps temporarily, I would just suggest to them that, well, the underlying cause is instability, so you need to get prolotherapy, but you could put PRP around the nerves. So often when somebody has radiculopathy or they have a nerve irritation, a better approach is PRP. So why does PRP help platelet-rich plasma, and what is it?
PRP, platelet-rich plasma, is where we actually draw your blood and we'll concentrate basically the good stuff out of your blood, is what I say, the growth factors, all the things that you need for healing. So if we take those concentrated resources and we inject it around a nerve root or even into a joint, we use guidance for those, then we actually can actively regenerate and repair the tissue as opposed to just putting a temporary painkiller in there.
Yeah, and then some people, they want you or me to be very exact. Like say you diagnose somebody with like L4 radiculopathy. So do you ever use guidance, and what kind of guidance could you use?
I use guidance. I use ultrasound to guide all of my lumbar injections. So you can see the facet joints pretty easily on ultrasound, and then even just by knowing your anatomy and tracing down, you can actually see the space where that nerve will come out, and so you could easily put PRP around the nerve or in that facet joint using ultrasound.
Yeah, that's for sure.
Mm-hmm.
I just put this in here, the functional spinal motion segment. I kind of like it, which is just two adjacent vertebrae, and then basically it's the ligaments that control motion. And a lot of people, they often think of it's the muscles that control motion. We have very, very big muscles in the lower back because the ligaments by themselves just can't bear all the weight of walking and sitting. But the muscles are basically the ligament backup. Mm-hmm. And once you get excessive motion of the bones, the ligaments, then when they can't control the motion, then what they're going to do is through a neurologic reflex called the ligament muscular reflex, they're going to cause the muscles to tighten. So anybody with chronic muscle tightness, which of course a very common symptom we hear is that the people are really, really stiff. Because if the primary problem was the muscles, you could just get a massage. You could lay off of tennis for 2 days and you would get cured, but you never get cured because it comes back. So the muscle tension is a protective mechanism.
So I get a lot of patients, like I said, with low back pain, and I'll say, we know already this is not a muscle problem because you've done it all. You've done massage therapy, you've done dry needling, you've done physical therapy, you've done all the muscle things, and not to say that those aren't good, but if this was a muscle problem, you would have fixed yourself, you wouldn't have ended up here, So what are those muscles protecting? What is, the next layer to helping you get rid of your tightness? Yeah. And I just want to show here, so this, it says number 1 here, but that's where your facet joint is. So if you kind of look at this, if this area, if this facet joint and those ligaments are weak and this whole thing is moving more, one of the byproducts is actually going to be your disc. So just, people that have disc degeneration and disc issues, that, there is a really a big facet joint and capsular ligament component to that too.
Yeah, that's a good point. And then they just kind of showed us that. Why don't you explain what's going on here?
Sure. So these are 2 different views. So this is kind of like we're looking top to bottom through the spinal canal. So here's your vertebrae. This is the back part of your vertebrae that you could feel, if you touch your back. Here's your spinal cord. And then these are the nerves coming off of it. When your bones move more than they should, it's quite likely that they'll actually touch or encroach on or even pinch whatever's around them. And your nerves actually lay right next to your bone, which is a protective thing. So your nerves should be protected by your bone. But if your bone is moving too much and your nerve lays right there, they can get pinched. So that's what this is showing, is if you actually have excess like rotation or instability, your nerves are going to be what suffer. And even over here, you can see like this vertebrae has moved forward as compared to this bottom one, and this canal where your nerve is, if this vertebrae moves forward, that nerve is right there, ready to be pinched.
16 years ago or something, after a bike fitting, I did a race called the American Triple, and then it was basically 4 races in a weekend, and my lower lumbar got injured and my pubic symphysis got injured. And ever since that time, for many years, I had clicking, cracking, popping in my neck, and needed a bunch of prolotherapy, and you've done periodically prolotherapy on my back. So that, it's not normal for somebody to have clicking, popping, grinding of the, low back. So if you have that, you do have instability. This is just an AP, a pelvic with some of the lower back in it. And this was one of our patients. And the first sign that a joint's getting too much stress on x-ray is called sclerosis. So if you look at this carefully, you could see the L5, S1 facet joints here. They're much wider than the ones up here. So for whatever reason, this is getting a lot more pressure and force in the SI joint here. And what would be the reason that a joint might be getting more force on it?
Yeah, so the sclerosis is kind of this more like bright white color that you see. So it was actually explained to me once like this, like when your joint is unstable, one of the things that you might actually see on imaging is like cysts that kind of form on it. And followed by sclerosis, followed maybe by bone spurs. So if you think about like a joint that's unstable, if it's moving too much, the cysts that start first are kind of like a protective thing. Like if you've worn shoes that are too tight and you get a blister, like from that friction, your body will like produce that to protect it. And then if you think about, if the joint continues to be unstable, well, instead of just creating cysts all the time, the bone will start to kind of harden more. Like you'll get that sclerosis. So if you have a pair of shoes, again, that it's too tight, you'll get your blister. But if you keep wearing those shoes, you'll get that kind of hardened callus. So it's a very similar thing that I think that's easy for people to understand that happens in your joints.
Yeah, for sure. I just wanted to talk about how many treatments for chronic low back pain, and then what's prolotherapy like of the lower back. Do most people need pain meds? Do most people don't?
Not every person needs the same number of treatments, right? So it depends a lot on what patient's goals are. If somebody wants to be able to play tennis at a high level versus somebody that wants to be able to walk in their home, it's going to be a different treatment course. I would say on average for a low back, about 5 to 6 treatments, usually about once a month. And depending on, again, the patient and what their goals are, we might opt to do things like PRP, or we might use, standard dextrose prolotherapy. Patients that throw their back out, in my experience, tend to respond better if we start with PRP right away. With anything, injections anywhere are going to be painful. Injections to the low back are going to be painful. I would say most patients that I see don't need pain meds. They might opt for laughing gas, but most people don't need pain meds unless maybe if there's someone that does have a lot of tight back muscles, a lot of spasms. Those might be people that benefit from a muscle relaxer during treatment.
Do you normally have somebody wear a sacroiliac belt or no?
Usually, yeah. If someone has an SI, joint instability, or even a lower lumbar, most of the time I actually do put them in that belt, because in between treatments, we want to try to like hold together the glue. And people, whether they realize it or not, they put a lot of stress on their low backs and their SIs if they are slouching,
Yeah,
if they're sitting at a computer a lot, if they're they work in a hospital and they're on their feet a lot. They put a lot of stress on their low back. So I find that the SI belt just helps to provide a little bit more stability while things are healing. And to be honest, it seems to help patients heal better or quicker.
That just brings up another point. Like sometimes the chronic low back pain, it is the sacroiliac joint,
Yeah.
and not the lumbar spine. So we'll do another video on the sacroiliac joint. And just want to thank you for your expertise, and thank you for watching.
Thanks for having me. Thanks.